Today I want to talk about the top 3 things to consider with hormones and bone health. In doing the research for my book, The Top 10 Reasons Why Your Hormones Are Failing You, I ran across a body of research on hormone replacement and bone health. And there is a lot to learn from this research, and it would take me a few hours to go through it all. I'm not going to do that, but I will show you my favorite 5 studies, which drive home my points around the top 3 things to consider for HRT: form, dose, and rhythm. So let's remember that hormones are powerful tools for bone health. And this year I've been traveling around the country, talking on stages to audiences, small and large, about hormone replacement therapy and bone health. And I don't want to bore you with all the research, but I do want to talk about these top 5 studies on HRT and bone health. What's so unique here is that many practitioners in the hormone space have never seen these studies. They probably aren't reading bone health journals or osteoporosis journals even. And that's okay, because that's not necessarily their specialty. But before we get to the studies, let me point out that what I'm going to talk about is different than what most doctors are prescribing today. See, we have to remember that we are in what is known as the post-Women's Health Initiative era, and hopefully we're getting out of it soon. But prior to the early 2000s, when both the 2002 and 2004 publications from the Women's Health Initiative came out and just devastated the hormone replacement therapy industry, prior to that, there was a lot of work in trying to figure out what the best type of hormone replacement therapy was. What forms, what dose, what rhythm. There were a lot of different varieties and a lot of customization to hormone therapy. After the WHI came out, when most people were taken off of their hormone therapy, those that still used it were encouraged to use as little as possible because of the potential risk of estrogen and the potential risk of the other hormones. And so they basically went to this very low dose model, and then it became very easy just to use a low static dose and do the same thing every day. So when you hear me use the word static, that means that the dose doesn't change throughout the week or month. It's the same dose every day. But we know in our practice, because we measure bone turnover markers, that this doesn't work for most women. What we've learned after years of prescribing HRT for women with osteoporosis is that there are considerable variables to consider. Again, form, dose, and rhythm. So let me talk about some of these studies. So this first study is called The Usefulness of Bone Turnover in Predicting the Response to Transdermal Estrogen Therapy in Postmenopausal Women. Now, that's perfect. That's exactly what we want to know, right? Now, this study is from 1997, and it really stands out because of the unique protocol. So listen to what they did. So they used an estradiol patch, which you all know is not my favorite form of estradiol, but it is still a bioidentical form of estrogen. So this is an estradiol patch of 0.05 milligrams per day, and they went 3 weeks on and 1 week off, meaning that they took the patch off for an entire week. And then they used 10 milligrams of medroxyprogesterone acetate, also known as Provera, and that's a synthetic progesterone. It's a progestin, and they used it on days 13 through 22 of the month. So clearly these women were keeping track of their timing during the month. There were 90 women in the entire study, and there was also a control group. So the control group was given calcium because we're looking at bone mineral density, so you got to give them something. Standard of care is calcium. So the control group was given calcium, and after 24 months, they lost about 2.3% of their bone mineral density, and that's not surprising, right? That's what we would expect to see. Now, in the intervention group, the group that was on the estrogen therapy and the medroxyprogesterone acetate, they actually gained almost 4% of their bone mineral density over the course of 24 months, which is a difference between that and the placebo of around 6.1%. I'm sorry, that's the control group, not technically a placebo. So that's cool in and of itself, right? 6% compared to control. However, they also went a step further, and they looked at what's called high turnover versus low turnover with bone metabolism. And you may have heard me talk about this. And we can measure bone metabolism in different ways. The way they did it in this study was kind of cool. They used what's called whole body retention of a labeled methylene diphosphonate. And that's basically a fancy way of saying they were able to monitor how quickly their bones were processing. So they were grouping these individuals into either a high turnover group or a low turnover group. And in the high turnover group, the hormone replacement therapy actually resulted in almost 9% increase in bone mineral density over the course of 24 months. And the low turnover group was less at 5%. So still pretty darn impressive, right? And so I think what this goes to show is that hormone replacement therapy can have a bigger impact depending on other factors than not. And so there are some people who are, if they are higher turnover individuals, which I would measure with CTX and P1NP, but if they're higher turnover individuals, they're more likely going to benefit from hormone replacement therapy. And we see that pretty consistently in our practice. Now, other takeaways from this study are that these forms are not my favorite. So I definitely don't like the Provera. That progestin, I think, should not be used. Now, an estradiol patch is a reasonable option. I don't love it for variable reasons. That's a topic for another video, but at least it is a bioidentical estradiol. I think the other thing to note here is that there is a dramatic response, right? Almost 9% increase in bone mineral density with what I would consider to be pretty suboptimal forms of HRT. So take that for what it is. So the second study is pretty cool. This one's called The Effects of Transdermal Estrogen Delivery on Bone Mineral Density in Postmenopausal Women, a meta-analysis. And so this is from 2017. And while it's actually not a great meta-analysis, I think the way they did the analysis was a little wonky. But what's compelling is that they basically did the research to compile all of the recent studies that were using topical estradiol, which is how I like to do it, and the impact on bone. So that's pretty cool. And one of the things that really stood out is that we were able to look at the different styles of prescribing. So what was their rhythm? What were their forms? What were their doses? So we can actually now compare of those three things that I said, form, dose, and rhythm, and we can see which ones perform best in these studies. So what we see is that there are actually 5 studies using a rhythmic approach. And I'm going to explain that in a second. There were 2 using a fully static approach. I already talked about that. And 2 doing a bit of both. Now, let's just take a second to talk about the rhythmic approach. Because when I talked earlier about a static approach, that's what the vast majority of people are on, right? So women typically are going to be on the same thing every day. There's no rhythm throughout the month. It's called static HRT. And that is the standard of care. No question. If you go back and look at these studies, though, from the early 2000s and 90s and probably before, especially in Europe, most people were on some kind of a rhythmic dose. So what does that mean? Rhythmic dose means that the progesterone especially can be cycled. And if you think about the way that hormones fluctuate up and down for women who are cycling, when they are going through their monthly cycle, they'll have estrogen rise and fall in the follicular phase, and then progesterone rise and fall in the luteal phase. So that push-pull does a whole lot of things. So we can start to mimic that in various forms, all the way from cycling progesterone, on-off progesterone, and maintaining static estrogen, all the way up to true physiologic restoration, which is actually trying to mimic to the best of our ability the rise and fall of estrogen and progesterone, which is a whole another topic for another day. But all of these studies in the what I would consider the rhythmic group used some form of rhythm. Usually it was cyclic progesterone, if not also cycling estrogen up and down a little bit, not like true physiologic restoration. So if you just look at this meta-analysis from the big picture perspective, you can see that the rhythmic group saw bone mineral density improvement from around 6.6% to nearly 10% in 12 months. That's a lot. The static group didn't perform as well, with what we'd usually see in studies on estradiol, about 2 to 4% increase in bone mineral density. And you can see this figure that I put together here. This is a comparison with all the PMIDs. So if you want to pause this video, look these studies up. You're welcome to do this research yourself. And you can look at all these studies on PubMed with these PMIDs. And you can look at the protocols and what I have the results in here, and they're bolded. So it makes it easy for you. Something to notice here is that none of these studies use what I think is what the evidence supports as the best way to use BHRT, but we have to use what we have. So in summary of this study, I would say that the biggest takeaway is that A, there's a lot of studies on estradiol and bone health, and B, rhythm seems to outperform static across the board. But there are some caveats here because we also need to talk about dose. We need to talk about form again. So we're going to look at that in some other studies. But before we get to our next study, if you are struggling to understand what the heck is going on with your hormone health, if your hormones are serving you the best they could, or if there's something missing, or maybe you have some symptoms that you think are related to hormones, but your doctor won't test them for you, just bypass all of that. Go to our masterclass where you can learn more about the symptoms of hormone dysfunction, dysregulation, non-optimized hormone replacement therapy. And in that masterclass, we'll talk about the common myths and misconceptions around HRT, the risks, the perceived risks, and then we'll leave some time for Q&A. So look for the link for that in the description. All right, let's move on with our third study here. So this study is called The Prevention of Bone Loss with Alendronate in Postmenopausal Women Under 60 Years of Age. Now, you might be thinking to yourself, alendronate sounds like a bisphosphonate drug, and it is. So alendronate is a bisphosphonate. It's an anti-resorptive drug. And so what I love about this study is that it's actually a drug trial. So this is a relatively big study. It's a drug trial that allowed open label HRT. So while this is not really an HRT trial, I think it does a really interesting job of looking at the bisphosphonates versus HRT and then different styles of HRT. So I think this is actually a really cool study. Now, it's also funded by the pharmaceutical industry, so it's pretty big. There's 1,600 individuals, 1,609 to be exact. And then there were two different forms of hormones. Not my favorite forms of hormones, but they used Premarin and Provera, so CEE and MPA. And then in Europe, they used oral estradiol, so also not my favorite, but at least it's estradiol. And they actually used a kind of a rhythmic approach. So they used 2 milligrams of oral estradiol days 1 through 22, so mimicking the follicular phase, although kind of a long version of it. And then they used 1 milligram on days 23 to 28, so that estradiol level would drop, and you could kind of see that would match the luteal phase. And then they used 1 milligrams of norethindrone acetate, which is another progestin, on days 13 to 22. So they're rising a kind of a progesterone on days 13 through 22. And then they start over on day 1. So they're running 28-day cycles with these women. Now, what's really interesting about this study, and this makes me laugh, is that the author's conclusion was that alendronate, the bisphosphonate, prevents bone loss in postmenopausal women under 60 years of age to nearly the same extent as estrogen and progestin. It's interesting. Does it? Well, we'll find out. So they actually did a really good job in this study because they looked at 3 different areas in the body and the impact of the hormones versus the drug in these 3 areas. And so they looked at the spine, they looked at the hips, and they looked at the forearms. And what's cool about that is that the spine, the hip, and the forearm all have different types of bone, different amounts of cancellous versus cortical bone, or the spongy versus the hard outside of the bone. Those 2 areas of bone change differently under different circumstances. So this is actually a really, really cool comparison. This is one of my favorite studies. And so in the placebo group, they lost about 1.8% of their bone mineral density in 24 months. Not surprising, right? Now, this is in the spine. The bisphosphonate group gained 3.5%. And this is what they show in the bisphosphonate studies, and that's why doctors use them, right? Okay, great. The static dosing gained 4% of their bone mineral density, which is not that different from the bisphosphonate group, but the rhythmic dosing gained over 5%. So while you could say that 3.5% and 4% might actually not be statistically significantly different, certainly 5% and 3.5% is. So to say that it's the same, I think is probably a stretch, right? But just wait, it gets better. So in the hip, the placebo group lost 1.6%. Now, the bisphosphonate group gained 1.3%, not quite as impressive, but this is the hip where there's more cortical bone. The static group gained 1.8%. The rhythmic group gained 3.2% bone mineral density. So here, the rhythmic group really outperformed the static group and the bisphosphonate, right? Now, it gets even worse in the forearm. So in the forearm, the placebo group lost 2.5% of BMD. That's a lot. The bisphosphonate drug did not protect bone mineral density in the forearm of these patients. We don't always measure forearm, but it's really compelling. And the reason why forearm is different is while the spine has mostly spongy bone, with just a little bit of cortical bone, the hip is kind of a mix, about 50-50 maybe, has a really thick cortex, but it also has a fair amount of spongy bone on the inside, depending on your bone. But the forearm is almost all cortical bone. Like it is just a tube of really hard bone with very little bone marrow in the middle. So it is a tube of very hard bone. And because of that, it's going to change more slowly and it's going to need different inputs. So again, placebo lost 2.5%. Bisphosphonate lost 1.4%. Static group actually lost as well. So the static hormone group lost 0.3%. But the rhythmic group gained 0.5%. So not a ton, but at least the rhythmic group maintained their bone mineral density. So again, the author said the bisphosphonate is nearly as good, I think is the term they used, as HRT. I would say that that is not the case. Okay, we're almost done. Stick with me here. I'm going to wrap this up for you in the end and tell you how we look at form, dose, and rhythm here in a minute. But before I do that, this next study is called a clinical trial of 3 doses of transdermal 17-beta estradiol for preventing postmenopausal bone loss, a preliminary study. Now, this is a study that I pulled and I put in here because it's one of the only studies that looks at levels in blood of estradiol, which I think is really important. And this is all the way back from 1998. But what's cool here is that they used 3 different doses of estradiol, and then they used estriol as a control. So let me explain that for a minute. Because we talk about estradiol, it's E2, it's bioidentical estrogen. That's what we want to use. Estriol is actually really commonly used, and I think it's mistakenly used to protect bone. Now, what I loved about this study and why I include it whenever I can is that they actually say, the authors in this study, they say, we used estriol as a control group because we know that it doesn't protect bone. I think somewhere over the last 26 years, we forgot that because I see a lot of providers using what's called biased, which is estriol and estradiol. Sometimes it's 80% estriol, and they're going to tell their patients that this will protect your bones. And it won't. So we see this in the study. Now, I shouldn't say that. It could if it had enough estradiol in it, but the estriol is not going to protect the bones. So the results of this are pretty clear, and they're kind of what we would expect. The lowest dose of estradiol improved bone mineral density by 4.8%. Pretty good. The highest dose by 8.7%. Even better. The estriol group lost 1.44%, and that's what you would expect to see in a placebo or in a control group that isn't on any estradiol, right? So estriol clearly doesn't protect bone. Now, this study was also interesting because they separated the group by surgical menopause versus natural menopause. And this is something that I hadn't seen so clearly painted before, but this just shows how severe the hormone drop is in women who've gone through surgical menopause. So if you look at the estriol group in the surgical menopause group, they lost 7.8% of their bone mineral density. Wow. Now, the estradiol groups gained 10% and 13% respectively, so the extremes were just so far apart. So the takeaway from this is simply that levels matter. But remember that these levels are going to be variable. You may have heard me say previously that we aim for 60 to 80 picogram per ml. And while that is our starting point, because that's based off of the literature, what we know is that some women need more, some women need less. We are also measuring other biomarkers, FSH, P1NP, CTX. We need to verify that the estrogen receptors are getting saturated, at least in the bone, and we hope everywhere else. Okay, so one more. All right, so our 5th study is called The Influence of Modified Transdermal Hormone Replacement Therapy on Concentrations of Hormones, Growth Factors, and Bone Mineral Density in Women with Osteopenia. Now, I think this is an interesting protocol because it really mimicked to some degree physiologic restoration. Not perfectly, but it's the closest I've ever seen in I wouldn't call it a large study, but in a published study. And so what they did here is they had a control group, and then they had a group that used a kind of a rhythmic approach. And it's kind of interesting because they were using patches, and they would start with a 0.025 patch and then graduate to a 0.05 patch, and then they would go up to a 0.075 patch, and then they would do that twice, and then they would start over. So 4 patches, 4 weeks, starting at a low dose and then working your way up. And then they would use, from progestin perspective, they used, I forget what it actually was, but they used a progestin for 12 days throughout the month with a lower dose and then a higher dose. So again, trying to mimic estrogen rise and fall and progesterone rise and fall. And then they had what they considered a static group. Now, the static group, they gave them estradiol and estriol, so technically it's a biased. And then they gave them another oral progestin. And they did that for 21 days on, 7 days off for all of them together. So it's kind of static, even though they did actually give them a break at the same time. But 21 days on, same thing, and then 7 days off. So they're just sort of cycling it that way, which is interesting. And so what I like about the study is that they did measure levels, but they didn't measure it in a way that I would want them to because they measured it between days 18 and 20, which isn't really what I want to know. I want to know probably days 12 and 21 would be my preference because we're kind of catching sort of like the rise of luteal progesterone probably, and we're seeing the fall of the estradiol. So these levels don't mean as much as I would like them to. And so what you see is they measured estradiol, and in the rhythmic group, estradiol went up to 56. So you might say, well, it's okay. Maybe it's enough. It might be. We need to look at other biomarkers. And then in the static group, they reported that it went up to 244, which is really high for 1 milligram of estradiol. So kind of interesting. That would be a pretty high level of estrogen. And then if you look at the FSH, what they show is that the placebo group, the FSH didn't change. And this stands for follicle stimulating hormone, for those of you that don't know what I'm talking about. And then in the rhythmic group, it did fall. We want it to fall to probably around 30 is what we aim for. And it fell to 49 in the rhythmic group and 45 in the static group. So not a big difference between the two. But in the bone mineral density outcomes, there is a big difference. So the placebo group lost 3% BMD. That's a lot. The rhythmic group gained 3.8% bone mineral density. It's a fair amount. And then the static group gained 2.2. So again, rhythm outperformed static, even though the dose in the static seems to have been very high. So how do we wrap all this together? These 5 studies I just presented here, what does it mean? Well, some big points that I want to put forward. Number 1 is we don't use synthetic progestins. We use micronized oral progesterone for the vast majority of our patients. And that is, in my opinion, the safest way to use progesterone and works the best for, again, the vast majority of our patients. Remember that not all hormone replacement therapy is the same, and I would strongly encourage measuring bone turnover markers and other biomarkers to understand if the HRT is doing what we want it to. Our favorite biomarkers, we get a whole long list, but the ones that I would say are absolutely critical are estradiol, FSH, P1NP, CTX, progesterone to make sure you're getting some, and then some whatever androgen you're taking, whether it be DHEA, testosterone, whatever, make sure you know what your androgen levels are as well. And remember that form, meaning bioidentical topical estradiol, in my opinion, micronized oral progesterone, and then whatever androgen you're using, the dose has to be adequate, and then rhythm is something to consider, but really has to be done correctly. So consider who you're working with that if you're going to find somebody who is open to doing that. But most of all, this has to be done individually. We have to understand that every woman is different. None of our patients are on the exact same thing. Everyone needs to be considered uniquely. So that's it. I hope that made some sense and could clarify some of this hormone craziness that you see on the internet and hear from your doctors. And just remember this, that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is the beginning.